Happy Friday, everyone. This is Ray Pedden from the Center for Care Innovations. Welcome to CCI's Raven e-learning series. The Raven e-learning series has been developed to highlight technology solutions that address priority areas that have been identified by the safety net provider community. It is designed as a learning laboratory to discover and connect digital health solutions and solve our toughest problems. The Raven e-learning series is designed to be a learning opportunity, and we encourage attendees to engage with the faculty during the session. Please put your questions into the chat window, and I will moderate and make sure that our faculty have an opportunity to answer your questions, and we'll have a robust discussion. Today's session is focused on reimagining the front end patient intake. We will be discussing how to reimagine your patient intake process, how to imagine using tablets during patient intake, and how to imagine improving your waiting room experience and increase the timeliness of patient-supplied data. Stay in the loop and join raven.careinnovations.org. Our distinguished faculty for today is Charles Kitzman, the Chief Information Officer from Shasta Community Health Center. Please welcome our distinguished faculty. Charles?
Can you hear me?
I can.
Excellent. Well, thanks, Ray. Hello, everybody. I was just checking the list of folks that are on the call. It's nice to see some familiar faces. Story, Jen, Carmen. Yeah, so today Ray asked me to kind of talk about a project that we did a few years ago. I'll be the first to admit that it was an interesting project, but it was unsuccessful, and I will talk about some of the reasons for that. Hopefully there'll be some lessons learned. There seems to be a lot of movement in this space currently, and full disclosure, we're looking at possible solutions to implement now that the vendors have seemed to kind of caught up with the processes and have overcome some of the barriers that we experienced. But anyway, it's good to be here. It's always fun to work with the Center for Care Innovations and general and Ray specifically. So thanks, Ray, for the invite. So that's today's agenda. You can see it on the screen. I'm going to talk about the problems, the approach we took, the barriers, the outcomes, and some conclusions. All right, so what's the problem? The big problem for us is that histories, we need it. We need that in the EHR. And historically, we've been live for over 12 years. And I think that it's something that we've always struggled with. We have complicated patients that often have very lengthy histories. And just the pressure points of in the busyness of a clinic, it's very difficult to get that information in. And so there's a whole host of workarounds that your clinical teams probably employ. Like if you have scribes like we do, they'll type the same thing over and over again into the HPI, which is wasteful as well. But the more important thing is that it's also, it not only duplicates labor for the staff, but for the patient as well. And I think we can all agree that making things easier on the intake is a worthwhile goal. So why are histories important? Well, they help inform decisions. Obviously, if you know somebody has a family history or they've had surgical history for something and they're presenting with different symptoms and things like that, tying those pieces together to make clinical decisions is pretty important. And so having it there is nice. It allows for proactive treatment, and it can reduce costs overall in the system, which is part of the quadruple aim. But they're difficult because there's no EHR that handles capturing histories well. It's often time consuming. and it isn't prioritized typically, at least in our practice. If it were, they would slow down and get it in there. It's repetitive and frustrating. You have to have some rules for data inclusion. You can, if you're not careful, you can get bad data into your system. So it's kind of on the honor system. Sometimes you have to think about, well, are we going to enter that the person had a pap smear, for example, recently, if we don't have proof that it actually occurred? And what kind of risks do you incur by not having a burden of proof for some of this historical stuff? So that's kind of tricky too. Timing can be tricky. By that, I mean that a lot of the energy that we want to put into the front office has to do really with new patients. If we have an opportunity to gather information in advance prior to a first visit, that would be great. But you have to have a chart created for them, and so being able to use some of these forms, even remotely, sending them to the patient to fill out in advance, that can be tricky if you don't know who they are. You have to verify who they are and stuff like that. And then I think we can all agree that a lot of the forms have a lot of the same data. And so that kind of exacerbates item number 3 in the difficult column there, that it's repetitive and frustrating because they're not only being asked every time they come in, but they're being asked the same thing, even on different forms, which is frustrating. So this is it's dated, but it's an example of a report that we use in our operations quality committee, and you can see it's color coded. We do have a centralized check-in for 5 of our departments. Those are indicated by the blue. Telemedicines as well. So there's 6. So those departments are served by a centralized check-in. The ones that don't have a blue are just kind of a regular, go to the department and check in. You can see that obviously there's room for us to improve. The lobby wait times are pretty tall. In fact, the only one that looks really attractive is telemedicine. If you look at the stack there, pretty quick, not too long in the lobby, 12 minutes, 8 minutes in the patient room, and then 28 with the provider. The goal really should be to have all of your columns look as much like that as possible. And you can see we've got tremendous variation. The reason for that is that operations process analysis teaches us that our most expensive resource should be our choke point. That should be where the patient is spending most of their time, with the provider. And so telemedicine is a perfect model for that, at least the way that we run it. And these are some of the numbers that support the previous slide. We track our encounters throughout the EHR for, when did they show up? When are they ready to room? How much time do they spend in the room with the nurse? How long do they wait for their provider? How long are they with the provider? Some of it is systems-based, some of it is carbon-based, which is to say that human beings have to do this activity. And you can see that middle column. There's some encounters when we're doing this analysis that we simply have to throw out because somebody forgot to update, and the length of time for that is not realistic, and obviously they weren't here for over 4 hours and things like that. But this is a regular data set that we look at in our operations quality structure in that committee anyway. So the approach was, and I know that there's a lot of vendors that are out there that are doing this, but remember, this was a few years ago. APIs weren't open. We had to really do a lot of work to try to figure out how to do this internally. And we did that with the help of a grant from the Center for Care Innovations. And as I mentioned at the top, we weren't successful. We had some barriers that we had to get over, but we're a culture that we're fail friendly. We want to fail first or fail early so that we can learn. And then, we've learned a lot, and we've learned how to analyze things, and we're circling back to this as a future project, and maybe you are too. So the idea is to have iPads or kiosks in the lobby. we want to capture consent forms, but our big focus was the historical data. We had run some analysis and figured out that we just weren't capturing it correctly. This is around the same time that we joined Sac Valley MedShare, which is our health information organization that serves 15 counties in Northeast California. And so in conjunction with submitting our data to Sac Valley, we really wanted our CCDAs to be as robust and useful as possible. And our early analysis was that, yeah, we're capturing things, but we're just not doing it correctly. And so that was kind of the goal of the project. So the idea was to push some of this to the patients so the staff don't have to do it. The staff were skipping it either at the behest of the provider who wanted to keep moving or for other reasons. But the idea was to have them do that in the lobby, have the data be viewable when the patient's roomed by the MA or the processor. The data needed to be authenticated. We didn't want to have just an open system where as soon as they hit save, the data is already in our system because we wanted to be able to review it with them. And again, that gets back to the data integrity piece. Once it's in the system, all of the EHRs that I know of, the data carries forward. It's held as demographic data, and it moves forward. And then input is you just update it. So you can, once it's in there, you can create documents that instead of giving them a blank form to fill out again, you show them the information that you have on file, and if there's anything that's new, they can add to it, or they can edit if anything happened to be in there erroneously. So we had to figure out, how are we going to measure this? What is success going to look like? What's our ultimate goals and things like that? It is a new process. The units were going to run on the wireless. They're going to have a session. Is the session going to be secure? Is it going to, have a lot of stability? Will it be intuitive enough for them to get it without a lot of hand holding? What percentage of the patients are going to be successful? How many are going to time out? How many are going to opt out? You can do some of that stuff up front with surveys and things of that nature, but we tracked a lot of this stuff throughout the project. So we wanted to also see if this would have an impact on access. We use the word access as kind of a cultural thing. Providers don't like the P word, productivity, but mostly because it's financial, kind of a financial term, whereas access is more of a patient-centered term. And the idea, obviously, is just to create efficiency so that you can serve more people. Most of us are impacted adversely by the shortage of primary care providers. And so we have to make the most with the resources that we have. And so you could tell by that cycle time report that there's definitely some room for us to make inroads on creating some access. Why is that important? Well, if you're in the FQ world, having your unduplicated patient count go up instead of down is terribly important to your 330 grant. And just, I think I can go out on a limb and say that all of the mission of just about all of our organizations has to do with serving people that need care. And if you're not serving everybody already, there's definitely work to do. So access measures, length of time, wait times are a big quality indicator for everybody. I'm sure all of you do staff satisfaction or patient satisfaction surveys quarterly or annually. So there's questions specific to that stuff. So it's important to the overall experience. And then the check-in staff. There's some folks that prefer, that person-to-person contact. And so we did find that a lot of our patients opted out of a digital check-in. So the staff feedback, these are parts of the questions that we would do for ongoing surveys. These are, you can pilfer these. I think Ray will probably give the slide deck out to everybody, and you can build your survey tools accordingly. But you want to you need to measure the impact. Is it working? For the people that use it, you want to try to survey those folks so that they can give you the feedback that you need. I would also add that patient advisory groups are a dynamite source for information from patients. You can vary up your advisory groups by demographics, by age, by experience, by acuity, and things like that. Those are helpful to do in advance of any project that's going to kind of change their experience within the health center. But these are some questions that we thought were pretty good. And then productivity, and this is kind of the nuts and bolts business model where we want to know how many scanned forms. Obviously, if you're still dealing with paper, then the paper has to go back to your medical records department. You're paying, somebody to index all of that and get all of those consents. And if you're capturing the history on paper and you're keeping it instead of abstracting it, then there's costs associated with that. We also wanted to see if there was any kind of call efficiency that was gained by the front office worker not having to enter as much data or deal with the patients as much. If you give them the process, they're kind of on autopilot until they're done, provided that they're successful, and that should free up the front office staff to do other things. And then the claim rejects based on inaccurate data, that was going to be to see if there was anything in the histories that lent itself well to E&M coding, and if the patients were good at it or not. The patient flow, obviously this is kind of an operational slide, but also how many patients, are we increasing access? Are we increasing access for new patients, existing patients, those types of things. And then that cycle time report that was that I showed you earlier, we'd want to see some movement on that as a result. For better or for worse, it's just an important thing to look at to make sure that you're analyzing impact. And we already had the tools for much of this stuff. The second item there, I just wanted to point out the platform that we used. I'm not going to mention it because I don't want this to be a commercial or anything, but the packet that we used had additional patient education materials that are available after the submission on the history. So the patient would go through the process, they would hit submit, and then it would automatically open kind of an online magazine. And we passed clinical data through it. So if the person had a history in our system of diabetes, the content of the magazine would be specific to the patient. So there would be some recipes for healthy eating. There would be just diabetic education and things like that in there, which was a really cool feature. And we wanted to obviously track to see if folks were plowing through that material and to what extent. So the system would actually capture page views, and they would use the email address that we had on file, if we had one on file. And from the platform, they'd be able to email themselves any of the articles that were in the online magazine. It was kind of a cool feature. So on the patient feedback questionnaires, these are some of the questions that we wanted to ask and get some feedback on. It was kind of a fluid project because it's all digitized. You can change things pretty easily you can modify the forms, you could modify the skip logic by which the forms operate, and things like that. And so the feedback from the patients is always, solid gold. So this is just one of those boring, geeky schemas that put you all to sleep. So we can go to the next slide. So how did it go? Well, it was good and bad. Our wireless was not awesome. It's awesome now because we just went through a major upgrade in our infrastructure. But at the time, it was a little bit tired, and we were in the middle of our equipment cycle. So as a CIO, I'm in charge of all the equipment, and we do servers and routers and switches, and 1 year, and then we'll do our wireless the next year, and we'll do workstations and the next, and things like that. We were right in the middle of that cycle, and so the equipment wasn't brand new awesome, but it was okay. But consequently, the iPads would get a wireless drop and the sessions would hang, and that could be frustrating. And if that's not working well, you kind of poison the well, especially for first-time patients that jump on it. So for those of you that are thinking of having a front office solution, your first thing is just to analyze your wireless access points and make sure that you have enough of them in that particular area. Now ours were situated more in the exam room area, back in the actual in the clinic, and so we added some access points after the fact. But my advice to you up front would be to go, make sure that you map those out and you got a really strong signal, and then test it. You might have up to 5 units running at the same time. Can it handle that? And so that the pre-testing is important. Patient buy-in was a bit of a barrier. We've got some funky pathology up here in the North State. Shasta County is not a hotbed of health and wellness, and so we also have a lot of distrust of institutions, and so our patients don't like to be dictated to too much. Maybe different where you're at, and maybe if you can staff it up properly, you may just make it the only option you have. Of course, it's technology, so you need contingency plans, but having some discussions about how to promote it and how to sustain it up front are probably some pretty good ideas. The staff buy-in, it was varied. We tried 3 different departments, and they all had different opinions and attitudes about the project. One of the things that they really didn't like was you have to clean the unit, in between every use. And, when you add cleaning iPads to somebody's job description, you're going to get some different responses. Some of them are like, okay, this is the new normal, I'll go ahead and do it. And you got other people that are like, I didn't sign up for this. So that was kind of a barrier. One of the things that happened with us, again, it was the HIE piece, is that we have terminology standards for all of our data, especially all of our data that goes into a CCDA. Back in 2015, 2016, that wasn't the case for all of our data, but so a lot of the stuff we had to do ourselves. The vendors have caught up, and most of that stuff is already in your EHR now, but we had to kind of manage that process. And we had to park the data somewhere in our system so that our staff could view it before they accepted it. And we didn't want to create custom fields in our EHR just for this project because that can complicate upgrades and things like that. So we had to use existing fields. And when we did that, and this was really kind of the deal breaker for us, was that it had some collateral interference with other work, particularly our quality department that was using a lot of those tables. And even though the data was in there temporarily, it could adversely affect, reports that were being run, and it would skew things up. And at the time, if you're trying to build a culture where your data is reliable, you can ill afford, to have a project like this, however grand the goals might be, to start interfering with well-established work. And so that was a big deal for us. So the outcomes were that the data parking issue was simply too hard to overcome. The staff, they never really, I think one department out of the 3 embraced it. The providers kind of just had better attitudes and were kind of behind it and served as cheerleaders, but it was difficult to get a lot of buy-in. And that's kind of a management issue. That's I wish I had a secret, this secret sauce for fixing that, but I don't. The patients weren't really ready for it. I think it kind of cut along demographic lines. Surprisingly, there'd be some folks that were a little advanced in age that would just grab it and go, but not many. And so we ended up pulling the plug on it and focusing our efforts elsewhere. And like I said at the top, we're to a position now where we're vetting vendors, and my early kind of investigations into the platforms that are out there mitigate some, but not all of the barriers that we experienced. The data parking is not such an issue anymore, I think mostly because the APIs are open, and it's just easier to manage. So some conclusions. If you're going to go after this as a challenge and as a project, organizational leadership and persuasion are very, very helpful. Make sure you have the right people at the table. Where we were successful, or at least where we found some success in terms of attitude and embracing and things like that, the manager for that department had a history of working the front office. So she had been with the company a long time, spent a few years as a front office worker, went to school, got her degree, and became a center manager. And I think that kind of understanding of the processes helped her to sell the idea to her staff. I think there was, in other departments, the leadership have different backgrounds. They could be clinical or nursing or something like that. And I think with project management like this, I think that matters sometimes. Promotional tools to get the word out. We tried our best. It was all internally. We didn't put anything on the website and say, hey, come in and use an iPad. But there were posters and things and some how-to. But a lot of it was pretty intuitive. But a lot of our patients did need some assistance. So you might want to think about maybe some volunteers. If you're going to try a project like this over the summer, you could use some high school students, summer students, to come in and help you with the project. A lot of that, it's right up their alley. They get to work with patients and kind of help them through the process. So it's pretty good work, pretty good process, good project for them. Your hardware and data processes need to be reliable and vetted up front. And so those are there's some questions that you want to ask of your vendors to make sure that the data types all match and the mappings are all appropriate, and that you're not going to be putting garbage in your system. And then the thing, this is interesting, and it's just kind of my perception, but the providers didn't seem to value the histories as structured data as much as I thought they would. And I think it's a style question. They do include historical information when it's appropriate. They just do it incorrectly. They just put it as a narrative or something like that, and they repeat it over and over again. A lot of that has to do with the way that EHRs display the histories. They're less intuitive, and so it could boil down to training, how the provider's trained and things like that. But I'm always of the opinion that the success of any kind of part of your practice is directly related to how much attention it gets. And if the histories were indeed more important, I think the providers would have clamored a little bit more for the support staff to fall in line and get it done and make it work. And then the other thing is that maybe we were too early. I think the technical 2.5 years ago is a lifetime in technology terms, and I think the tools that are out there now are much better suited to manage this type of stuff. And when you try to innovate, sometimes you do go too early and things like that. But I think down the road, we have a fully functional HIE up here in Shasta County, and our data goes twice a day to to the hospitals or into Sac Valley MedShare. So any of our patients that are seen anywhere else who's a client, our neighbors and partners have access to our data almost. It's not real time, but it's pretty close. Our data has legs now, and I think the provider community is starting to realize that when they look at a CCDA and they see that something's blank, they don't assume that this patient doesn't have any history, right? They ask the question, and then other data contributors can get those histories in there, and then those histories can be consumed if the patient comes back to us, provided that they're accurate. But so there's a lot more data sharing going on. But I'm going to go ahead and stop there. I think I've burned half the hour. I don't know, Ray, how much time you've booked for us. I think it's an hour.
Yep, we're up to, we have another 29 minutes or so available. That doesn't mean that on a Friday before a long weekend we have to burn it all. Charles has probably got some plans for the afternoon and the weekend, but most of all, what I'd like to convey is, Charles, thank you very much. I mean, every time that I've been involved in a discussion with you or asked you a question or asked for your help in terms of coaching others that are thinking about doing new and different stuff throughout the safety net, you have responded with world-class demeanor and information. And I really want to, on behalf of the entire safety net, I just want to thank you for taking time on a busy Friday to lay out something that you tried to do and are still interested in doing, and help people understand a little bit about the barriers and about the kinds of things that we have to pay attention to. So with that, I would like to open it up to any questions that people have. Please use the chat box, if you will, or unmute yourself and go ahead and shout your question. I'm sure Charles would be very happy to respond. Here's one from, I think it's Ilicia Lopez. Specifically, can you share more information on the application used to complete forms?
So the vendor was Seamless Medical, and they had their own proprietary product. Their CEO was he was personally frustrated as a patient, you know, filling out forms and stuff like that, and so his vision was to create something that would work to capture histories and things like that. Now, for us, the platform was also, as I mentioned, very educational. And so there was really kind of two goals. One would be to educate the patient, make custom quality content that's easily digestible. And they did a lot of work, kind of getting it down to a 5th and 6th grade reading level and stuff. They employed some high quality educators and clinical folks to make that go. That part was pretty slick. The functionality on the forms, the mappings and stuff, those were pretty straightforward because most EHRs have discrete fields and you could just map those to the forms. They were great to build out of the box, but they weren't great to modify. That took a lot of time. Alicia, I don't know if that helps to answer your question, but that's about all I can say on that.
Okay, another one just came in from Jennifer Durst. She says, hopefully she didn't miss you mentioning whether or not you use simple screeners like PHQs, audit, reg forms, prepare, etc.
Yeah, so that would have been a phase 2. We've gone after PHQ2s in different ways. For kids, we digitized the Staying Healthy assessment, and then for the younger kids, we actually we don't use the SHA for that. We digitized the whole child assessment, which has tools, additional tools. It's actually longer. It's a more lengthy risk assessment for kids, but it includes the 2 questions for the PHQ2. And so that's all digitized. And if that triggers a 9 or a PHQ-9A, then we have that in our system to do that. But yeah, ultimately you'd want to kind of front load. It's not a bad idea to have them fill out these forms. One of the barriers, I think, is not all your patients are going to have the ability to read and understand all of those questions clearly. What we've found is having a clinical person kind of at least be there and kind of talk them through or answer some questions is helpful. But you know, depending on your demographics and who you're serving and things like that, there's always some opportunity to create efficiencies by front loading those. It's a great idea.
Other questions from the community for Charles?
I wouldn't mind asking the group if anybody has successfully implemented, you know, like Freesia or OTEC or even Seamless. I mean, I think our problem with, you know, the barriers with Seamless were that we were trying to serve 2 masters at the same time. They're not a bad vendor. They're not a bad client. The failure was on our side, I think, pretty clearly by trying to serve 2 masters at once. And ultimately, the HIE piece in our quality programs took precedence over the project. And we were willing to, you know, take the time and wait until you know, better opportunity time-wise and project-wise and pressure point-wise. Just, you know, better availability and all of that.
So who out there in our community that's on the session today is attempting this, and what sorts of technology platforms are you looking at besides paper in order to reimagine your front end? And you can either take yourself off mute or respond through the chat window. Jennifer Durst responds, we're looking into it. We've looked at GetWell and Luma Health. We're looking into a solution that does more than only patient intake, but also outreach, etc. I'll let you know how it goes. And so I'm going to recruit Jennifer for a faculty member on a future session.
See, there you go, Jen. You open your mouth and boom. But thanks for the intel. I'm writing those down. I'm unfamiliar with both of those, so thank you so much.
Another question. You mentioned, and this is from Summer Penn, you mentioned that you showed the patient their histories to see if it was accurate and if there were any updates. Was that on an iPad or some other modality?
Yeah, so if you use, that's a great question. So if you use if the patient uses the product once, then we'd have the ability to show them what we have. And so when they would sign in, it would show them, and then there was, you know, a button like to add, you know, and it would ask the question, do you have any additional historical information to provide? And they would just say yes or no. And it would, you know, go through family history, you know, medical surgical history and stuff like that, and then even the social histories. And you know, to that end, I think it's also not a bad idea if you don't have a digital solution and you have a lot of folks. I mean, most folks have had EHRs for a long time and have, you know, made some considerable efforts, you know, to capture these histories and things like that. And if you have, and you have the ability to create a document that does kind of show sort of succinctly a patient what they have on file, it's always a good practice, I think, to let them review what you have on file. Because one of the things that we learned on this project is that a lot of the info that we have isn't accurate, and they thought it was at the time, or things have been, they're like, you know, I don't have that. My dad never had that. Where'd you get that? And we're like, well, we got it from you, but somebody may have, you know, fat fingered it or, you know, clicked the wrong thing and stuff like that. So there's, a good way to correct the information.
I have a question from Philippa Barron, and this is for the community in the session today. Does anyone know if it's fairly easy to use iPads with Epic for patient intake purposes? We're moving to Epic in the next few months.
I don't know.
Yeah, Philippa, I have some people that I'm happy to introduce you to that are Epic users. Are you on Ocean Epic, or are you going on what I call Madison Epic? Okay, well, we're waiting for that. Phil, anybody else have any questions or contributions they'd like to make to the discussion today?
Ocean, okay.
Philippa responded she'll be on Ocean Epic. Be very glad to talk to somebody about this. Philippa, you can reach out to me, ray@careinnovations.org. I can do the introductions. Be happy to put you in touch with some super users on the Ocean Epic platform. Question from Christina Modi. Does anyone have a good overview of the screening platforms available? And I'm assuming that when you mean screening platforms, screening like Prepare, PHQ, and other screening tools.
Yeah, all the tools that we use are vetted through our clinical quality committee. Mm-hmm. And we usually, if it's a pediatric tool, then we have a lot of pediatric input. If it's, adult medicine, same, or if there's anything that's going to be used in behavioral health
Yeah, Christina, it sounds like it's a CCI project to put together a landscape on screening platforms, right? Okay, Joshua Reicher. He's a provider. He's with an organization called HealthNote, and he's just letting me know privately, but I'm broadcasting it to the group, that in this particular space, HealthNet is a new upcomer, and so if people want to add that to their inventory of possible technology platforms, please feel free. If you need more information on HealthNote, please feel free to email ray@careinnovations.org, and I can supply those kinds of introductions.
Ray, well, I have a contact that I just messaged and got a reply from, who's an Ocean Epic client. And
perfect.
She reports to me that they have on Epic, they have the capability to turn on certain features to use tablets with medication history and health history updating, as well as some other things. It's a closed system, so what you get is what you get. So in terms of being able to expand and innovate, it's a little bit limited. They did a pilot and they couldn't get it going, mostly because of some staffing changes and stuff like that, but they're going to try it again.
Hopefully that's helpful. And again, I can help you talk to some other folks as well. We're at 45 minutes now, and things seem to be slowing down a little bit. Any last minute questions? This session has been recorded. It will be available on the raven.careinnovations.org website, so you can go back and watch it over and over and over again. And I invite you to do so, and you can also invite others to come and watch the session as well if you think it's valuable for them. I especially want to thank Charles, for taking the time today on a Friday afternoon to share with all of us. And I hope that everyone found at least a part of it useful. And I look forward to our next e-learning session, which I think is not yet published, but it'll be sometime on it'll be at noon on June 14th. And it's trying to help folks understand how to best use telehealth in a MATS environment, specifically trying to use that tool to effectively address some of our addiction treatment programs. So with that, I want to wish everybody a happy Friday afternoon. Charles, again, thank you from the bottom of my heart. Really appreciate you being willing to share this much.
Yeah, no problem. Always a pleasure. Have a great holiday weekend, everybody. Stay safe out there.